Welcome to this edition of Clinical Clips, an accredited continuing education activity. This brief expert video will spotlight the daily hot topics from the conference.
Hello, welcome to Clinical Clips. I'm Dr. Cindy Neunert, and I'm an Associate Professor of Pediatrics at Columbia University Irving Medical Center. And today we'll be reviewing some important findings at the 2024 EHA Congress, specifically as they relate to pediatric ITP. So one of the things that was discussed at the EHA meeting this year was understanding how we can address the needs of our patients better. And this came about in a session entitled Bridging Generations in Immune Thrombocytopenia Care, Adult and Pediatric Perspectives, Unmet Needs, with a lot of focus on this unmet needs. They started by highlighting the ASH 2019 guidelines for ITP with a focus on second-line therapies. And they focused on this question, which was, should children with ITP and non-life-threatening mucosal bleeding and or diminished health-related quality of life, those who are not responding to first-line treatment, should they be treated with a TPO or rituximab, TPO-RA or splenectomy, or rituximab or splenectomy? And there really was a bit of a hierarchy from the guidelines in terms of their suggestions, which was TPOs rather than rituximab, a TPO rather than splenectomy, and rituximab rather than splenectomy. So sort of TPO, then rituximab, then splenectomy. These were all conditional recommendations based on very low certainty in the evidence, which is important to have that context. So they spent some time sort of breaking this down, recognizing that guidelines may not always align with the needs and the perspective of patients and families, as well as a lot of providers and medical treaters may not really fully appreciate the burden of the disease and or medication side effects experienced by the patients. So a lot of the focus around this discussion was on the TPO-RAs, and we now have a lot more data to support that suggestion from the guidelines that the TPOs sort of be our first-line therapy that we go to in those patients that have failed first-line therapy. This data here shows the long-term use of L-thrombopag in children with chronic ITP, and what's great about this is that it's actually real-world data. So there's a movement to try to present real-world data outside of clinical trials, and I think that really is an important piece of what we need to now be doing as clinical trials are closing, but we're starting to use these in our clinical practice. And what you can see here, this is a probability of remaining on L-thrombopag during the follow-up period. And you can see that slowly there's a drift downward in those patients that had to come, of those patients that stayed on therapy, with some either coming off or transitioning to another therapy, or perhaps because of the medication not fitting with their lifestyle any longer. So we can get some idea of what's happening with these medicines and how we're using them in clinical practice. So parallel to this, they did see that when stopping that long-term treatment with romipilstim, there was some treatment-free responses. And we've seen discussions about this in adults. So can we transition children off of a TPO and have them go into a drug-free response? And this was showing for a different therapy for romipilstim that a probability of achieving a treatment-free response was related to age at the first dose and also having a good response pretty quickly to the medication. This is more data on romipilstim for children with chronic refractory ITP. This is a smaller subset of real-world data in 18 children, just showing some good efficacy data as compared to controls, showing a reduction in that need for rescue treatment. And we'll talk about that a little bit more with some of the other studies that we'll see. Here again is some additional real-world data showing just response rates, but showing that patients were able to discontinue therapy and remain in a complete remission. This study did have one patient with a provoked deep venous thrombosis that's important to highlight. This has been a well-described and discussed safety signal in adults that we have not seen quite as frequently in children, but there are occasional reports of it occurring, and this is one of those examples. So something to be mindful that can still happen in the pediatric population with the use of all of these medications, not specific to any one drug. So now we come to some exciting new clinical trial data, and this is for avatrombopag. So currently, L-thrombopag and romoplastin are the only two that are FDA approved for children, and avatrombopag is now in clinical trials for pediatric patients. And you can see here that they enrolled patients greater than 1 or less than 18, confirmed diagnosis of primary ITP, for 26 months, who had an insufficient response to previous treatments. Those previous treatments were not dictated. It could be any previous treatment. The primary endpoint was a durable platelet response. This was defined as the proportion of patients achieving at least 6 out of 8 weekly platelet counts greater than 50,000 during the last 8 of the 12 weeks of the core phase of the treatment period. And this was in absence of any rescue therapy. They also had some additional platelet count outcomes, as well as looked at safety signals and bleeding symptoms. So let's spend a little bit of time looking at the data. This shows us the baseline data on the patients. As expected, our average, the time to ITP diagnosis at enrollment was 3.1 years. Our platelet count was significantly low at the time of enrollment. Many patients were previously treated with greater than 3 prior treatments. Interestingly, there are patients on this study that did switch from another TPORA onto this trial. And the majority of patients were able to complete the 12-week core phase. This shows response rates. So here is the number that I think is the most meaningful. This is the primary outcome. That's that 28% of patients having that durable platelet response. We do see a much higher number if we just look at 2 consistent platelet counts over 50,000. And then a day 8 platelet response greater than 50,000 was seen in half the patients, which is actually quite encouraging that perhaps this gives a pretty prompt response in platelet count. And then what you can also see here is a dramatic reduction in that use of rescue therapy to 7% compared to 43% in the placebo group. This is just another way of looking at the median platelet counts in the absence of rescue therapy, again showing median platelet counts in the treatment group with avatrombopag, and then down here is our placebo group showing a consistently higher median platelet count. They did look at safety, and what they found here was that headache was the only treatment-related adverse event that was reported in more than 1 patient. The only 2 serious adverse events were headache and thrombocytosis, and these occurred in 1 patient in the avatrombopag group and were considered to be treatment-related. But otherwise, the medication was well tolerated as compared to placebo. So in summary, they said that they showed that avatrombopag resulted in significant improvement in the primary efficacy endpoint of durable platelet count response and platelet response as compared to placebo. And secondary efficacy endpoints were also significantly improved with avatrombopag. The safety profile was reassuring with no new safety signals, and it may offer benefit in terms of monitoring and administration as it doesn't have dietary restrictions. Including the ease of that oral dosing, where sometimes we can even taper this from a daily medication. And this may overall reduce that treatment burden that I was talking about in the beginning that is obviously noted by our families and something that remains an unmet need. There is some other data out there on avatrombopag, mostly retrospective and observational. There's a retrospective study that again showed a good increase. Slightly more patients in this study required rescue therapy with 27%. 2 studies have shown that patients can effectively switch from L-thrombopag to avatrombopag. So this shows us that if we have a patient that is not responding to a TPORA, it's quite feasible to consider a different medication. And then we also had an observational study showing a good platelet count response, but this was more focused on COVID-19 infection. So here's how we have to monitor these drugs. We've talked a little bit about the patient burden, side effects. So here's our common side effects, things that we have to be mindful of. Some of them we can simply dose adjust. That's in reference to our platelet count. If we see a significant fall off in our platelet count after we've had a response, we should consider looking for a suspected anti-drug antibody, which we can do testing with the drug companies. We can consider if our patient's actually getting the medication, adhering to the dietary guidelines, and then also thinking about, is there any reason to look at the bone marrow because of the signal for increased bone marrow reticulin? Patients can see rebound thrombocytopenia with abrupt discontinuation. And in this setting, there's a lot of discussion about how do we taper these medications, how should we stop them? And then I mentioned the venous thromboembolism, or the VTE, which has not been seen in children as much as in adults. Transaminitis is mostly with L-thrombopag and does need to be monitored, as well as the cataract formation with L-thrombopag that really has not become a safety signal and was more in patients that were also receiving other medications. This just sort of compares these side by side, showing you dose, route of administration, sub-Q versus oral, our starting dose, and then if there's an actual pediatric indication at this time. And I can tell you the selection of these is really about sitting down and figuring out which of these medications is going to work best for the patient that you're seeing in your clinic that day. And this is where I think Dr. Granger at the end of this session really spent a lot of time on the concept of shared decision-making. And with all of this data, and there were several sessions even highlighting new medications coming out for adults. And so as we expand available therapies, we have to start thinking about how do we make the right choice for an individual patient. And this is really a collaboration between the patient and the family and the clinical team to support them with knowledge, to provide them with the confidence to make decisions by talking with other patients and families, and to provide valuable resources to really assist them in thinking through what are their core values, what are they trying to achieve with a therapy. There is a patient guide that has been created by the ITP support group in the United Kingdom, and this is a really good reference for patients, and it is available online. Because we need to really empower our families to be part of this decision with us. I think this will lead to better adherence, it will lead to better satisfaction, it will lead to better communication about how we're doing once we decide on a therapy. And so now I'd just like to switch gears a little bit. We're talking a lot about the TPORAs, and we're talking about them in the setting of the pediatric population and what's new. But I think the other area where we have a huge unmet need in ITP is with pregnant women. And this was a poster presentation looking at the safety and efficacy in pregnant ITP patients and their babies from an Italian study. And it was a small group of 14 pregnancies, but still did show good outcomes with regards to use, starting at the TPO start, getting the women through delivery, and then continuing for at least 1 month after delivery. And there was no significant impact on the infants either. So I think that this is, again, a growing place where we're starting to recognize that the TPORAs may provide really good therapy for our patients in a space where we oftentimes didn't have a lot of good options. It's really been a pleasure to speak with you all about ITP and share with you all of the exciting things that were presented at the 2024 EHA Congress. Thank you again for joining us, and please return to the landing page for the download slides and to access other related topics. Thank you so much.
We hope you found this activity useful and educational. To receive continuing education credit and to download your printable certificate, please return to the activity webpage and click on the Claim Credit button associated with today's clinical clip.